All right, good morning, everyone. We're going to get started. Today, we are privileged to welcome Dr. Lisa Winston and Dr. Ayesha Appa. Dr. Winston is a professor of medicine and the hospital epidemiologist and associate medical director for medical surgical services at San Francisco General. And Dr. Appa is an assistant professor in the division here of HIV, ID, and global medicine. Dr. Appa and Dr. Winston are fantastic clinician educators, and we're truly honored to have them share a report back from IDWeek. They are going to give us a lot of information today, so get ready and please warmly welcome them. Thank you.
Thank you, Liz. Good morning, everybody. As Liz said, I'm going to dive into this fantastic laundry list of studies that I had the privilege of consuming during IDWeek. As you can see, this is way too many to cover in the next 25 minutes, and I'm going to keep an eye on my watch. But it was really, it was a wonderful meeting to attend. Really great to connect with people and consume some of the science. I'm going to try to cover the highlighted studies here. And I'll just keep an eye on the time. And one thing for context, I'm going to sort of motor along relatively quickly. Hold on to your questions until after Lisa's talk, and then we'll try to make time and space for all of them at the end. So I'm going to focus on our HIV topics, and then Lisa will focus on general ID. Let's dive into our first study. So this, the first couple studies that I'll take us through are taking a look at real-world use of long-acting cabotegravir, rilpivirine in people living with HIV and detectable viral loads. Or other sort of social vulnerabilities that I think have, nice parallels for us to understand and contextualize our experience, which has been extensive at Ward 86, providing long-acting Cabril. So the goal of this study, which was ViiV funded and utilizing the Appa cohort, was to describe Cabril utilization among people living with HIV with a viral load over 50 in the last 2 years, and then describe the effectiveness during this interval. So the Appa longitudinal cohort that many of you may be familiar with is quite large, over 155K, as you can see, individuals, which is reflective of about 14% of people living with HIV in the US. And for this particular study, they included people living with HIV who had a viral load over 50 at their first Cabril injection, which you can see is during the time there, and that were not enrolled in a trial. And then they looked at any measured and last measured viral loads to look at viral suppression, either less than 50 or less than 200. So the study population, so who were these individuals? As you can see, of the 155K individuals living with HIV, about 1,800 were receiving CAB-LA injections, and then 229 had a viral load over 50 at initiation. And then I'm really going to focus on those with viral load over 200, as trying to get at this question of effectiveness of Cabril on this national, in this national sample. And for those who had a viral load greater than 200, the median viral load at Cabril start was 158,000 copies per mil, and you can see the IQR there. And then the demographics of this group, median age was 40, about half were female, 70% Black, and median BMI was 27, as you can see there. And yes, as I mentioned, we'll focus here, and then particularly we'll follow the yellow boxes going along. So what did they find? Achievement of virologic suppression during the follow-up period was notable for the following. So of those with follow-up viral loads, which was 69 of the 93 with viral load greater than 200 at initiation, 74% of those folks had a viral load of less than 50, and 90% of those had a viral load of less than 200. And I think the one other little note here, follow-up time was really heterogeneous and limited. The median was 8 months, but you can see the IQR was 4 through 11 here. And so then, the next thing that we really want to know is what about virologic failure? There were 7 cases of confirmed virologic failure. They did not present anything about resistance and mutations associated with this failure. And I will also just note again, to contextualize our experience, that 65% of this group that was studying was receiving Q2 month injections, and just 31% were monthly. I think, so, for this particular study, in summary, I think what are our take homes? 5% of this national cohort was starting Cabril off-label for treatment of HIV with a viral load of greater than 200. And participants were diverse with a median BMI that was in the overweight range. Of those with follow-up, you can see that 90% had a viral load of less than 200, and that we had 7 cases or 4% with confirmed virologic failure. Though we really need to know more, how many failed with resistance, and then what is the outcome of that 22 to 24% who did not have a follow-up viral load reported, I think because of the Q2 month injections and the limited follow-up period. So, promising, but again, very, I think, early days. And then this is, apologies, overwhelming. But what I will share is, I think, a theme of the meeting to put you in the shoes of wandering around IDWeek. There was that oral presentation of the Appa cohort, and then there were a number of posters, people describing case series or their experiences implementing Cabril, and I tried to sort of focus on those with populations that may be similar to our San Francisco general population, or those that focused on people with detectable viral loads. So just real quickly, highlights of these posters here. We had one that was a TRIO cohort study. TRIO Health is an EMR network this is a ViiV-sponsored retrospective cohort. And I included this here because they included 13, there were 13 individuals in this retrospective cohort of 315 that 14 individuals that had a viral load of 200. 13 of those 14 remained on Cabril at the end of this median follow-up period of 5 months. And of the 10 with follow-up viral loads, 8 of them had an undetectable viral load, so 80% viral suppression. 2 had possible virologic failure, and then they did not present data about resistance. There were the next 2 posters do not describe the use in people with HIV viral loads greater than 200, but did have some interesting implementation strategies. This first one was a group using in Columbus, Ohio, using an infusion center-based model. So this was a single center retrospective cohort of 64 individuals in Cleveland who again, all of which were suppressed, but alcohol, substance use, and mental health diagnoses were common between a quarter to a third of the sample. And they noted that of the total follow-up injections, 8% were late, though substance use and mental health diagnoses were not significantly associated with late injections. They noted 10 patients required bridging with oral ART. And I think overall, it was an example of a central HIV clinic pharmacist doing review and then outsourcing some of the implementation of insurance paperwork, follow-up, et cetera, to an infusion center, which is potentially more accessible for patients. And so they had success with that. Real world efficacy of long-acting Cabril in an urban HIV clinic, which was Cook County, is the third poster here. And this looked at 96 individuals, again, all of whom were suppressed. They noted that 7 had K103N, 1 had a V106I, most were receiving Q2 month injections to start. And of those with a follow-up viral load, 97% were suppressed. They had 1 case of virologic failure, despite a BMI that was not overweight or obese, on-time injections, and had failed with an M230L and V179E, essentially high-level rilpivirine resistance. And then the last presentation I will share with you. This was just another implementation innovation that described a group in the Medical University of South Carolina that enrolled 33 patients who could elect home-based cabotegravir rilpivirine injections versus in clinic. The patients had the option of selecting which they would like. And then one LPN drove across 3 counties to inject these patients that were being seen at home. They had their cab ril mailed to them and then kept it in the fridge. And that's sort of how that was done. Of note, patients could cross over if they felt like they wanted the more convenient, say, home experience, or wanted to remove their home from the medical sphere, wanted to go back to clinic. But essentially, most people who chose one of those arms stayed with those. And of those 33, 3 ended up switching to oral ART, and one had virologic failure, who had a historical genotype with a K103N, and an archive that was run during very early failure, in which they couldn't run a traditional genotype, demonstrated this really extensive resistance that you can see here. They subsequently suppressed on COVID, Dronabir, Fastemsavir, and DOR. So that is our roundup of IDWeek presentations on Cabril for socially vulnerable folks or people with detectable HIV viral loads. Next study that I will tell you about is effects of semaglutide on adipose tissue and HIV-associated lipohypertrophy. There was another interesting retrospective cohort study presented at the same time that I'll bring your attention to at the end of this talk, that was also looking at outcomes of GLP-1 agonist use. And I think just, telling about the state of HIV primary care, that those were both featured as oral abstracts. This study was a single-site randomized double-blind placebo-controlled study to look at the efficacy of GLP-1 agonists on visceral adipose tissue in people living with HIV. So this, the treatment group received subcutaneous semaglutide weekly for 8 weeks of titration, 24 weeks of an intervention, and then 24 weeks of observation. And there was a sham injection group. You can see the inclusion criteria. Notably, they excluded those with known diabetes or cardiovascular disease. And what were the results? In this group, there was median 52 years old, majority male, 62% Black, with a median BMI of 33. You saw that weight decreased by 8% essentially in the semaglutide group versus an increase of 0.2 in the placebo. And 65% of those on semaglutide lost over 5% of their body weight. Total fat decreased by 15% in semaglutide arm, and then visceral adiposity decreased by 13%. All very, very exciting findings. They did note that there was no statistically different decrease in pericardial fat or liver fat. I think interesting for future work, focused on fatty liver disease, et cetera. And there was a decrease in total lean mass that was disproportionate in the semaglutide arm. So what is our takeaway as HIV providers of this study? I think this was the first RCT of a GLP-1 agonist in overweight people living with HIV. And I think for counseling our patients, 2 of 3 patients lost over 5% of their body weight, with a median 8% reduction in body weight by 32 weeks. We do know, I think excitingly for sort of other comorbid cardiovascular diseases, visceral adiposity was reduced, though there was no difference in perihepatic fat and pericardial fat. We need to learn more about this. And then the other bit that, there was reduced lean mass overall. So, do we need to be also suggesting exercise to essentially ensure people or mitigate that loss of lean mass? I think this is my second to last study I will tell you about. This was 1 versus 3 weekly doses of benzathine penicillin in the treatment of early syphilis that included people living with HIV. So, this may or may not be news to you that there was a debate about how many doses of penicillin we should be using for early syphilis. There was a 2009 study of IDWeek providers that found that 60% were using 3 doses of penicillin for people living with HIV to treat secondary syphilis. So there has been sort of heterogeneous practice, and this trial was attempting to answer this question: what should we be doing? Particularly, I think, poignant in light of our benzathine penicillin shortage. So this was a comparative efficacy trial that included 10 sites. It was a randomized open label trial, and they set their non-inferior margin at 10%. You can see the inclusion and exclusion criteria there. I think that the main one I will draw your attention to is concurrent STI requiring T-pallidum active antibiotics. This actually led to 25% of their initial group recruited being excluded. And then the outcome to therapy was response at 6 months. Many of our sort of definition of cure are measured at 12 months. So that'll also be relevant in a moment. They measured failure as any increase after their first RPR and penicillin use. And what did they find? In this group that was primarily male, here you go, and 61% people living with HIV and 71% with high titer infections over 1 to 64. They found really no significantly different rate of response between 1 dose of benzathine penicillin and 3. And this finding was essentially the same in people living with HIV. I think one question that came up when presenting this prior that was excellent was, a response rate of 70, around 76%, isn't that lower? We think that, for people living without HIV, early syphilis cure should be 90 to 100% by a year. I think there are, when looking at trials that have looked at the trajectory, this was at 6 months. This is sort of within range for that 6-month finding. And then there were 4 cases of failure. The authors during the presentation, noted more will be learned as they bring this closer to publication. And B, I think their hypothesis was that there were some people who had an RPR drawn and clinically, for whatever reason, repeated really soon after their dose of penicillin, a day, 2 days after their dose. And because their protocol defined any failure as an RPR increase, if somebody was actually just on the upswing, they would be counted as failure. And so that was their hypothesis. But stay tuned for more. I think that in summary, I think this is generally supportive of our CDC recommendations to treat early syphilis with 1 dose of benzathine penicillin, including those living with HIV. We'll see more about the 12-month follow-up and results stratified by degree of RPR elevation and latency. Okay, and then last, longer study, and then I'll turn things over in the next 5 minutes, was an interesting presentation about PEP in pocket, or PIP. I'm gonna a little tongue twister here. But this group out of the University of Toronto was presenting long-term follow-up of their retrospective cohort of folks who had utilized PIP. So again, PEP, post-exposure prophylaxis in pocket for HIV prevention. So what is this? Proactive prescription for 28 days of guideline-endorsed post-exposure prophylaxis for patients to self-initiate and then attend clinic non-urgently after initiation for those who report 0 to 4 HIV exposures per year. This was done at two HIV prevention clinics in Toronto and Canada in this interval that you see here. And I liked, they shared a slide of, how are we thinking about this and how does this fit into the menu or the buffet of options that we have? And this is overwhelming buffet, I realize, but they're presenting this to patients as, those who have the most exposures may benefit from, really removing the variable of adherence and having injectable PrEP, and those with zero exposures may need nothing. And so PEP or PIP may fit in to the left side of that buffet or figure by the pasta or whatever that is. So what did they find? 112 people were prescribed PIP. 31% of them initiated for sexual exposures, and then about 70% did not. There was a split of those who used PIP once versus those who used more than once. And there were zero conversions during this period of follow-up. That again, actually the median follow-up, let me see if I have this on the slide. I don't think I shared. Enrollment was between 2016 and 2022. We don't really actually have what that follow-up period was. Oh no, we do. Sorry, 1.6 years. There we go. There was not really a range that we could understand. I think one of the more interesting things that they found, essentially there was good adherence. PIP was discontinued on a few occasions. There were about 30% of participants went from PIP to PrEP. And I think that seamless transition, and again, the offering of the menu was a nice reminder of this, of PEP in general, and then this model. So I think that is largely my summary, that it's a dynamic HIV prevention modality to consider alongside our others. And then for more in the way of rapid roundup, Paul Sachs and his blog that many of you may have seen covered on Halloween, a nice roundup of 14 studies with just sort of really headline highlights. And so an example of this is there was another study that I didn't have time to cover that was looking at mortality of patients, people living with HIV with cirrhosis at Duke. And they noted that 23% of those with cirrhosis died during a 3-year follow-up period, which is a huge mortality rate, despite largely having viral suppression. So, how are we doing in caring for those with liver disease, getting them to transplant, et cetera? So an example of a snippet that you can find there on that blog post. And with that, I will turn it over to Lisa. And if we have time, I'll come back to this poster about waking.
All right. Well, thank you so much, Ayesha. That was fantastic. And I am going to go ahead and dive right in because there were lots of interesting ID studies that were presented. So the first study that I'm going to present, if you only heard about one study from IDWeek, it was probably this study, the ACORN study. And it was timed so that the presentation at IDWeek came out the same day as the article came out in JAMA. The images that I'm going to show are going to be from the paper in JAMA. So this is cefepime versus pip/tazo in adults hospitalized with acute infection. And as Ayesha mentioned with the Paul Sachs blog, Paul was so impressed with this study that he dedicated its own blog post because he was very impressed with the structure of the trial. So it was pragmatic, open label, randomized, no need for consent. And basically what happened is if you were an adult in the ED or ICU in a single hospital and your clinician ordered cefepime or pip/tazo, the EHR asked your clinician if they would enroll you in the study. And then it facilitated what to order and what dose to order, either cefepime or pip/tazo. And we could argue a little bit, I think, about if this would be the preferred pip/tazo dosing, but it was a reasonable dose. And the duration of treatment and any other antibiotics were at the discretion of the clinician. And the study for 7 days after enrollment, if the clinician discontinued the antibiotic or they ordered the other antibiotic, the EHR alerted them that the patient was on the study and asked them about the reason for the change. So very practical. Again, this was done at one medical center. They accrued patients very quickly. And so they had about 1,200 patients who got randomized to cefepime and a little more who were randomized to pip/tazo. Their primary outcome was looking at a combination of acute kidney injury or death by day 14. And basically what they found was that there was no difference in this. And I think as many people are aware, people have been concerned that pip/tazo, especially in combination with vancomycin, might be associated with higher rates of acute kidney injury, but they did not find that. What they did find, so all the way on the right side of the slide, that is the acute kidney. They had a few different acute kidney injury outcomes, but that's one of them, showing no difference between pip/tazo and cefepime. But they did find that patients in the cefepime group did have more neurologic dysfunction. So they experienced fewer days alive and free of delirium of coma and coma within the first 14 days compared to the group that got pip/tazo. So in that analysis, fewer days is worse. You want to have more days free from delirium and coma, and of course, you still want to be alive. And but it was a modest difference. So, what can we say, I think, in terms of the ACORN take-home points? There really was no signal whatsoever for increased renal toxicity with pip/tazo, even though more than 80% of the patients in both groups received vancomycin. I think we can probably put that to bed. Interestingly, though, there was more neurologic dysfunction, although it was modest in the cefepime group. People have pointed out this was an open label trial. And so, could there have been bias in the ascertainment? I will just say, though, that the way this was ascertained was pretty good. So it was done by nurses recording on standardized scales the way they always do in their hospitalized patients. And it's actually not at all clear that the nurses were even aware that this study was going on and that people had hypothesized that there might be more neurologic dysfunction with cefepime. And then the other thing that was interesting is, we've hypothesized that, cefepime neurologic dysfunction only occurs in patients who have renal disease, so either CKD or AKI leading to higher levels. But that actually did not seem to be the case in this study. Neither CKD nor AKI had an effect modification. So what's the take home for us? Well, we have traditionally not used very much pip/tazo here. And Amanda Roy is in the audience. She and I have already chatted. We may start using it more and decreasing cefepime and, joining the rest of the world and using pip/tazo. But I think we are going to have to be careful about overuse. All right. So our next study, so this was another fun study getting at a real clinical problem. So this is the issue of what do you do when your patient has a complicated urinary tract infection due to an ESBL producing organism. They got better. They got, 4 to 7 days of IV therapy. You'd like to transition them to something oral, but maybe you don't have a good choice for what that would be. So this is a study from Korea that was done in 4 hospitals there. They had 199 patients who had complicated urinary tract infections, and the urine culture grew an Enterobacteriaceae organism that was ESBL producing, and it was phosphomycin susceptible. The total duration of antibiotics in both groups was 10 days. And the mean duration of phosphomycin and IV therapy, since it was a total of 10 days, was both 5 days. I reached out to the investigator to find out what dose of phosphomycin they were using, and it was 3 grams daily, which we'll talk about when we get to the endpoints of this study. Impressively, a quarter of the patients in the phosphomycin arm actually had bacteremia. So this was a pretty sick group, and their primary endpoint was clinical cure 4 days after the end of therapy. So a pretty relevant outcome. And what did they find? So in the top graph, they had set their non-inferiority margin at 15%. And you could see they did much better than that. It really did look like the two therapies were very similar. They met criteria for non-inferiority with switch to phosphomycin. I just did want to point out one thing in the specified subgroups, which was that, this was not statistically significant, not surprisingly based on the numbers. But in terms of clinical cure was numerically lower in patients with bacteremia who got phosphomycin. So it wasn't terrible, but, my take home, I think, is going to be that I feel pretty good about this strategy in patients with complicated UTI if I don't have another switch option. But I don't think I'm going to use it in patients with bacteremia. I think I'm going to continue those patients on IV therapy if they did not complete it in the hospital. And then the other thing that I just wanted to point out when they looked at their secondary endpoints, microbiologic cure with phosphomycin was quite high. It was just as good when you looked at follow-up urine cultures. But again, thinking about follow-up, are patients going to get readmitted? These numbers were really low, but there were a few more people in the phosphomycin arm who got readmitted than in the folks who completed the IV antibiotics. Again, this was an open label study, and but just something to keep in mind. So, challenges with this are really, I think, more logistical than scientific. Phosphomycin is expensive. It can be hard to get. It can be hard to get it paid for by insurance. And the 3 grams a day is not the usual dose. For uncomplicated UTIs, people sometimes get 1 dose, and then people have kind of tried this every other day dosing. For more significant infections. So I think that this is definitely something we can keep in our back pockets, but it will we'll need to be able to get the vancomycin in order to make it happen. Okay, next study. I thought this one was quite interesting and not something that I'd spent a lot of time thinking about. So we spend a lot of time thinking about follow-up blood cultures in patients who have Staph aureus bacteremia, but should we be getting follow-up blood cultures in patients who have gram-negative bloodstream infections? So this was a group from Duke. And they did a follow-up study to a prior study they'd done to validate their results. And they looked at an adult patient cohort between 2015 and 2021, when it was their usual standard to get follow-up blood cultures in patients with gram-negative bacteremia, which I would say is not our standard or many, not necessarily the standard other places. So they had about 1,300 patients, and 22% got no follow-up blood cultures, and 78% got follow-up blood cultures after being found to have gram-negative bacteremia. So what were the outcomes? Well, very interestingly, getting follow-up blood cultures seemed to be good for your mortality. So both the unadjusted, and then they went through a variety of ways to try to decide, if your attributable mortality was to your gram-negative infection or not. But both the unadjusted and attributable mortality were higher in the patients without follow-up blood cultures. So why was this? Well, it wasn't because follow-up having positive blood cultures was somehow weirdly associated with lower mortality. In fact, as you would expect, having a positive follow-up blood culture was associated with increased mortality. And interestingly, they had a really pretty high number of patients who had positive follow-up blood cultures, higher than I would have expected. I think it was about 18% who actually had positive blood cultures in this cohort. So, really interesting. So, how does this compare to prior studies? This is one study. The authors of this study helpfully pulled up a prior systematic review. Now, I will point out that their group wrote this prior systematic review, and their prior study is the largest study that's on here. But, I don't know, I think we were kind of busy in 2020 and 2021 when these studies were done. I completely missed this. But this actually, looks to be a trend. There are other studies that suggest that if you get follow-up blood cultures in patients with gram-negative bacteremia, that outcomes may be better. And they hypothesized that the reason for this is that if you're alerted to the fact that somebody has a positive blood culture, it may change what you do in terms of, do you treat longer? Do you look for source control? Do you do other things? They need to dive into their data more to look for that. And they also point out that there are probably patients that are low enough risk that you do not need to get follow-up blood cultures. I think that's probably true. But I actually put this study down as practice changing for me. I think for the time being, while more data are accruing, I am probably going to recommend in most of my patients who have gram-negative bacteremia that we go ahead and get follow-up blood cultures. I have talked about this with a few folks at Parnassus. I think that is a controversial opinion, but I think it's relatively low risk. It's if we get a few more follow-up blood cultures, although I would say not no risk, right? There are costs associated. You could get false positives. So, but this is a topic I'm looking forward to hearing more about in the next couple of years. Okay, so this next study I included because I didn't want you to think that I had lost all objectivity. And I found this study interesting, but unconvincing. But it did get a fair amount of press, so I just wanted to go through it briefly. So this was a study from Detroit Medical Center where they looked at if you combine vancomycin and cefazolin for Staph aureus bacteremia due to MRSA, do you have better outcomes? And interestingly, a few years ago, it looks like they changed their standard practice to initiate. So for patients with MRSA bacteremia, they just put them on vancomycin and cefazolin, and then they have a particular switch strategy, if they think patients are clinically failing based on positive follow-up blood cultures or other reasons. But I will point out that the retrospective observational cohort that goes back to 2006 probably predates this strategy. So when they may not be comparing apples to apples because the patients earlier on in that time frame probably did not get cefazolin, and people who were later in the cohort would have been more likely to get it. So this was their cohort. You had to have greater than one positive blood culture for MRSA. You always worry when you had to exclude most of the patients, thinking about, is this, going to be a valid result? But they did wind up with 124 patients who just got vancomycin and 145 who got vancomycin and cefazolin. So here were their results. So they found a difference in 30-day mortality. To me, this was implausibly large. This was a very large difference. And it's not consistent with previous studies of anti-staphylococcal penicillins like napsilin or oxacillin being given with vancomycin, where we actually haven't seen improvements. Also, it was really unclear to me why giving cefazolin would decrease the risk for AKI. I mean, cefazolin doesn't cause a lot of AKI, but it's also not renal protective. So I chalked this up to, interesting single center study. We can keep an eye on it. It's possible that it would turn out that there's a difference between cefazolin and the anti-staphylococcal penicillins. But I think these results may largely be due to the way their cohort was put together. And I do not think this is practice changing at this time, but good to have in mind. Okay, so now we are going to move into a couple studies looking at RSV vaccine, which, as many people know, huge deal last year when these data were presented and published. Then over the summer, we got approval of our RSV vaccines. Now we're giving it to folks 60 and older. But one of the questions has been, because right now the recommendations are if you're 60 and older and you get your RSV vaccine, the recommendation is just to get one dose. There's no recommendation for a booster. There's no recommendation for yearly immunization. And when the studies came out in the New England Journal, they were really preliminary in terms of the second year. They had their full data for the first year, but it did look like there was some drop in efficacy for the second year. So I think a lot of us thought that, kind of like we do flu every year. And, I don't know what we're doing with COVID yet, but it certainly doesn't seem to be one time. And maybe it's going to be yearly. I think we sort of felt like RSV was going to be the same way, and we'd have to do it more than once. So this study, which looked at the GSK Arexvy vaccine, so one of the two RSV vaccines, they looked at their folks who had been randomized to get vaccine versus placebo. And then at the beginning of season 2, the folks who had been randomized to get vaccine at the beginning were re-randomized to get another dose versus just to continue on as one dose. And very interestingly, the outcomes were exactly the same for the two groups. There was no difference in terms of lower respiratory tract disease, although the numbers get a little bit small here. And I will just also say this is over 2 seasons. They did not break out their season 1 and season 2 data separately. But that did not seem to help if you got the second dose. So that was their conclusion. The single dose seemed to work, but revaccination did not seem to provide any additional benefit. And they're going to continue to look at it, which I think will be helpful. And I just wanted to show one last slide that these were in their kind of extra slides at the end of their presentation, so they did not go over this. So I actually can't tell you what everything on this slide means. Like, I don't know what RSV flexible is, but I think what we can see is that at the initial time point, day 1, when you get your initial RSV vaccine, you get a boost in your RSV titers as you would expect. But for the people who were expected to get annual vaccines, when they got boosted between month 12 and 13, it didn't go up very much. So, and that's a challenge with some vaccines. Some vaccines just don't boost that well. So I think that we have a lot more to learn about, how we're going to protect people against RSV going forward. So I think there'll be a lot more information on this. Okay, so next study is, can you give RSV vaccine with influenza vaccine in older adults? And the context of this is, kind of where we are now based on data that got presented to the Advisory Committee on Immunization Practices and published on in the MMWR. And this is based on the GSK vaccine, is that it is permissible. You can give RSV and influenza vaccine at the same time. But they did note that titers to both, so both to the influenza strains and to RSV, were somewhat lower when you did that. And based on this, many people have said and have recommended to their patients, unless it logistically makes way more sense for them to get their RSV and flu vaccine at the same time, that maybe you want to space them by about a month, while we're sort of figuring out the clinical significance of this. So this was done by Pfizer, unlike the prior vaccine, prior data that was submitted from GSK. So this is the Abrysvo RSV vaccine, which is very similar to Arexvy. And they looked at patients who got RSV vaccine with the adjuvanted influenza vaccine together, and those who got it separated by a month. Everybody in the group that was separated, they got their influenza vaccine first, and everybody got looked at 1 month after their influenza vaccine was given. So it's either given with RSV or you got RSV a month later. And what did they see? Well, actually, they saw exactly the same thing that had been seen previously in the data that GSK had presented. So the higher part of the slide is seroprotection. So that's the levels of RSV titers. And then seroconversion is the rise in the RSV titers. And they were similar, but they were actually across the board a little bit lower in people who had it co-administered. So although the company said, this validates, practice that you can get them together, I think it validates practice that maybe you should have caution about giving them together. And if it is reasonably convenient for your patient, it may make sense to separate them by about a month while we're waiting to see what the significance is. And probably doesn't matter which RSV vaccine we're talking about. I will say that both of these sets of data that I talked about were with the adjuvanted influenza vaccine. That is not the most common influenza vaccine that we give. So it is possible that if we're talking about giving it with a different influenza vaccine, the results would be different, but we don't have data on that. Okay, coming down to a couple more studies. There's so much stuff that's really good. All right, so this was real-world dalbavancin use for serious gram-positive bacterial infections, comparing outcomes between people who use drugs and people who do not use drugs. So this was a study that was done at 3 of the Massachusetts hospitals, and they looked at their cohort of patients who got dalbavancin between 2016 and 2022 for 6 different types of infections. And you can see that the infection types, perhaps not surprisingly, did differ between people who use drugs and people who don't use drugs, although their groups were spread in both, with bacteremia being the most common. So how did the patients who got dalbavancin do? Well, this was very reassuring. They did pretty well. And it didn't matter if you were a person who used drugs or a person who did not use drugs, your clinical cure rate at 90 days, and these are serious infections, so these are infections that have appreciable failure rates, was pretty good. Now, not surprisingly, potentially, they did have more trouble keeping track of the people who use drugs, and there were more patient-directed discharges. But what I would say, look forward to hearing if Ayesha would agree, but I think this is definitely a good validation of our current practice, and certainly does not suggest that a self-directed discharge would be a reason not to use dalbavancin. In fact, for us, it is often a good indication for thinking about it. So, but it was nice to see this in another cohort. Okay, couple more studies here. Comparison of the diagnostic power of conventional culture and automatic blood culture systems with pleural fluid. So I'm not sure if people have thought about this very much with pleural fluid, but it's come up a lot over the years with peritoneal fluid. So when you send your culture to the lab, should you just put it in a sterile tube, or should you put it in a blood culture bottle? So a group at the Samsung Medical Center in Korea looked at this, and they looked at non-duplicate patients whose pleural fluid was tested using both conventional culture and blood culture system. They looked at 9,000 patients who had pleural fluid sent. They found 600 who had positive cultures that turned positive in the automated blood culture system. Fascinatingly, just in terms of the sensitivity of both of these, in this group that they screened, there were only 5 where the culture that was sent not in the blood culture system, that was just sent in the sterile tube, was positive, as opposed to more than 300 where it was only positive in the blood culture system and not in the sterile tube. And then they compared these groups. So what they found was that if the conventional culture had no growth, you could get either monomicrobial or polymicrobial growth in your blood culture bottle. If the conventional culture had monomicrobial growth, you frequently found polymicrobial growth if you sent the blood culture. And if the conventional culture was polymicrobial, most of the time, not 100% of the time, but most of the time, you also picked it up in the blood culture bottle. And you can see that there were a lot of organisms that were picked up. They excluded organisms that they thought were usually just contaminants, but, you know, kind of across the board, the blood culture system did better. So the lab was interested in this study. I think they have already been looking at putting together guidelines for which cultures should come to them in blood culture bottles and which shouldn't. And I think this will, you know, spur us to have a conversation about this. But there are some advantages to sending conventional culture. The main one being they can do an immediate gram stain on the fluid. So you may get some information upfront from that. And then I think Barb Haller wants me to mention that this doesn't mean that everybody should start sending everything in blood culture bottles to the lab. For example, synovial fluid is probably not a good fluid to send in a blood culture bottle. It's very viscous, not clear that you're going to get good results if you do that. So before you go rogue and start sending a lot of interesting things to the lab, great to have a conversation with them about that first. Okay, this is my last study, possibly the most exciting one in terms of its potential. And I look forward to hearing comments from people who know more about this than I do. But this was the evaluation of BioFire's global fever special pathogens panel. And although this presentation was done by the company, the technology has been developed with the Department of Defense and NIAID, and it is available. It's FDA cleared and commercially available. So we use a lot of BioFire products, but this one you use directly on whole blood. And it detects 16 targets and in about an hour, which is very impressive. So how did they do this study? They enrolled participants at 11 sites, interestingly, including 2 US sites, but they enrolled people all over the world. All you had to have was reported history of fever. So the inclusion criteria were very broad. And the comparison for the BioFire was a different type of PCR that was for single pathogens and used different primers. So I just want to point out that the comparator wasn't like doing a full workup for the pathogen, like, in thinking about malaria, the comparator wasn't like, did they do malaria smears? Did they do other rapid diagnostics? But then they compared, how this worked. So they were able to detect special pathogens by region. This was very encouraging because they detected things, where you would expect to detect them. And I was also pleased to say they did not seem to have a problem with false positives. So you'd worry if they were detecting, yellow fever in Washington, D.C. and those sorts of things, because that can be a problem with PCR tests. And that did not happen. And their positive percent agreement and negative percent agreement between the two studies, the two types of PCRs, was excellent. So their point of care study, the BioFire, did a very good job compared with the comparator PCR test in picking up what you'd expect. You see the viruses at the top, the bacteria in the middle, and the protozoa organisms at the bottom. So this is a really exciting potential way to make diagnoses very quickly, both for clinical purposes and potentially in the setting of concerns for outbreaks. So I'm going to, with that exciting news, I am going to stop. And thank you very much.
Thank you so much, Lisa and Ayesha. That was fabulous. Let's start with audience questions. Rebecca.
Hi, Lisa. Thanks for a great talk, as always. I have a quick question about the dalbavancin abstract. Was that 2 doses for everybody, or was it 1 dose only?
that's a great question. I don't remember if they said in their presentation. Ayesha, do you remember?
I do. You are a plant. That was my comment. It was really heterogeneous. It was a mix of 1 dose and 2 doses. And I think that what they were finding anecdotally and in talking to the senior author is that this works best, as you might imagine, for folks that you're worried about, say, leaving that are street homeless and that follow-up is going to be a problem. If they already have 2 weeks of antibiotics in them, and then you use your 1 dose of the 1.5 gram for another 2 weeks to get you to 4 weeks, that's more ideal to not have to rely on the second dose. I think in other series and in their series, they found it's not that you can't get people to come back and find people and really work on that, but adherence to the second dose has been reported somewhere around 60-70%. So it's not fabulous.
Yeah, Joe has a question for you.
I was just curious if they looked at outcome on plasma by infection type. There's a whole series of different, or rather than small areas.
Yeah,
Can you repeat it?
absolutely. So the question was whether they looked at outcomes by infection type. I think their numbers were really too small to have any meaningful information about that, but it's a great question. You could potentially think about pooling data across sites though, right? Because I think lots of people are gaining experience with that.
I have 2 questions, one for each of you. So for the PIP study, did they actually ascertain whether there was a true HIV exposure, or it was just people who had unprotected sex and were sort of theoretically concerned? And then my question for Lisa is, for the last study that you showed, it looked like some of the infections had 0 cases. So do you know if they're planning to try to test this for Ebola and Lassa and stuff, their follow-up studies planned?
Great questions. Yeah, so for the PIP study, they did not define exposure. I think they defined that the eligibility group was people who reported 0 to 4 exposures, and then people could self-select into, I am going to start using my PIP or not. So I think that it's helpful in my mind, if worried about PIP or PEP versus PrEP, it was helpful that in that group that was almost 70% who did not take their PIP, there were no seroconversions. I found that helpful, but yes, knowing true efficacy in a controlled setting, hard to know.
So thanks, Mike, for the question about the global special pathogens panel, and if further studies are planned, because fortunately for some of the infections, they found the event rates were 0. So they did not mention whether they had plans for follow-up studies. It's approved. So I actually think that probably the most likely thing we're going to start to see is real-world experience with people implementing it. Potentially, there are other technologies that people could be using, but I think we probably will start to see some real-world experience with people using it. And as is, I think probably everyone is thinking of, but one of the really nice things about it is if you can detect 16 possible targets at the same time, you might pick some things up really early before you are actually starting to suspect that might be going on, and that for certain pathogens that might really allow you to have a more coordinated response earlier on. But that certainly is an issue. I think we don't know how well it's going to pick things up for those lower prevalence targets.
That was really fantastic. Thank you so much. I'm going to make one comment about PIP. Last year at CROI, and we've published hundreds of cases of using pill and pocket in Africa, and a couple of things. As cute as it is, I don't like the smorgasbord, because people's behavior isn't like that. What people do is they switch back and forth from pill and pocket. And in terms of your question, our biggest thing is that people won't take extra PEP. It's more, we had a young woman who said, oh, I didn't think my boyfriend was at risk, and didn't take it, So in the real world, that is much more of a concern. But we did show also that PEP is a good onboard to PrEP, but versus telling people, oh, you should do this, versus people figuring out it themselves, we have a lot of options now. My question for you guys is a big question. Large language models, AI, I know that was a plenary, maybe one interesting thing that you heard about that at the meeting in terms of ID or HIV.
It was a great question. Thank you for that comment, Diane. I really like that about considering PIP in its, what is the right use case? Large language models and AI. Yes, the plenary was fantastic. Let me think about whether there were other sort of original research presentations that I went to that utilize this. Lisa, is there anything off the top of your head?
Well, so it was a really good speaker, really, interesting thoughts. And I would say, a couple of the take homes for me were that, we have to get involved, I think, a lot of us may not be early adopters by our nature. But this is coming, and if we want it to work and we want it to work well, that we really actually need to get involved and on board and understand it, because the plenary speaker talked about specific limitations if you really don't understand how it's looking at the data and the databases that it's using, but the potential if you do. So some of us will probably do it faster than others, but I think we're all going to be moving forward into the AI world, and we should be, I don't know if we should be running, but at least we should probably be jogging as opposed to dragging our feet.
Yeah, I love that. I think the two things that come to mind, I heard about natural language processing, or AI, as a tool to leverage in antimicrobial stewardship. How are we looking at all of the charts at San Francisco General and understanding prescribing behavior, or how we might modify or provide decision support to physicians or providers. And then the other piece that I've seen that's pertinent to sort of my area of interest is, how are we identifying people who use drugs or people with infections and comorbid substance use disorders, as ICD documentation is tough. There's stigmatizing language like abuse in the chart. There is people using use disorder terminology. How do we really identify who can benefit from combined substance use disorder and addiction treatment, or sort of effective models of HIV and ID care, using, again, that sort of sophisticated language processing that allowing identification of patients.
Awesome. I think we are out of time. Thank you so much. Those were great talks. Thank you.